Assalamu alaikum wa rahmatullahi wa barakatuh. Hello, everyone, and welcome to the first episode of the Libyan Pulmonary and Critical Care Practice podcast. I'm your host, Faysal Al-Ghoula, and every other Saturday from now on, we will be bringing you discussions, high-yield discussions focused on the pulmonary and critical care topics. Today, our topic will be chronic obstructive airway disease, or COPD. Joining us are two honored guests who are specialized in the field of pulmonary medicine and who have the special expertise in managing patients with COPD. Our first guest is from the United States, Dr. Mohammed Al-Megri. Dr. Al-Megri is a consultant pulmonologist and intensivist. He's a faculty in Marshall's University in West Virginia. He did his residency in internal medicine there in West Virginia, Marshall's University, and then he further specialized in pulmonary and critical care medicine, University of Kentucky in Lexington. Welcome, Dr. Megri.
Thank you.
Our second guest is Dr. Anas Zarmouh. Dr. Anas is a consultant in general medicine and respiratory medicine, currently practicing in Misrata Medical Center in Libya, and Dr. Anas did his core medical training in Leeds in the United Kingdom, and he did his advanced training in respiratory medicine in Sheffield in UK. Dr. Anas is also one of the founding members of the Libyan Thoracic Society, and he is currently the treasurer of the Libyan Thoracic Society. Welcome, Anas. Pleased to have you here today. Today, our topic will be the COPD. Start this podcast by a case presentation, and then we'll elaborate more on the next steps for the management of this patient. So our patient here today is a 68-year-old Libyan male. He is active smoker. He has a 30-pack year smoking history. His main symptoms is dyspnea and shortness of breath and cough. His shortness of breath, as per the patient's words, that he walks slower than his friends in the same age because of shortness of breath, and he must stop if he to take breath whenever he walks for more than 50 meters. The patient is also reporting some cough, which is intermittent. It's not always associated with sputum production. And he was recently hospitalized to the ICU, actually, because of hypercapnic respiratory failure in the setting of bad pneumonia. He required oxygen, required to be in the BiPAP, required steroids, nebulizers, and eventually he improved. He was discharged 4 weeks ago, and he presented to the clinic for follow-up. Excuse me. His physical exam revealed signs of hyperinflation like pearl chest with cyanosed lips and pursed lip breathing. He was otherwise vitally stable with normal SATs and room air. And he had diminished breath sounds with polyphonic wheezes bilateral on chest auscultation. His cardiac exam was normal other than loud S2 with wide splitting and trace lower extremity edema on leg exam. So I'll start by asking Dr. Mohammed Al-Megri to help us in interpreting these pulmonary function tests. Let me just move to the next slide. Dr. Megri.
So thank you for having me, Faisal. Looking at the lung function test or the spirometry, the first thing that I look at is, did the patient do the test in a way that it's acceptable and usable and repeatable? Which by looking at the curves and everything, and that we can talk about that in a different lecture. However, in here we can look at the inspiratory limb in the curve, and then the expiratory limb as well. So when you look at the expiratory limb, normally it should be like this one. But however, in here you can see the scooping in the inspiratory and the expiratory limb, and that goes with obstruction. And that's the flow volume loop. And if you look at the volume time loop, so I look at the first second, which is in here. So I look at the FEV1. FEV1 is around 0.9. So that's very low FEV1. And if you see, like it's raising slowly to reach the peak. If patient has a normal BFT, it will be like going like this. If it's like a patient has restrictive lung disease, it will be going slowly like this. So that's like one of the things that we can look at, that by looking at the curve, it looks like obstructive.
An interpretation for these numbers?
Yes. So looking at these numbers, the first thing that I look at the FEV1 FVC ratio. And by looking at the FEV1 FVC ratio, I look if it's less than 70 to define COPD. So in here, it's like 29%. And 29% that goes with obstruction. The next step, I will look at the FEV1 to look at the severity. The FEV1 in here, this post-bronchodilator, it was 23%. And 23% is a very severe or obstruction according to the GOLD criteria. And looking at, there's no any significant response. So I know there is no significant response to bronchodilator. Looking at the 2% in here, there's no any significant response. After that, I look at the total lung capacity and residual volume. So the total lung capacity in here, it's 121%, and it's more than the predicted, and yes, goes with hyperinflation. And looking at the residual volume as well, it's 219. That's more than the predicted. That goes with air trapping. And looking at the RV-TLC ratio, it goes with air trapping as well. The last thing that I look at, the DLCO, which is the diffusion capacity. And in here, it's a very severe reduction, 14%. Normally should be like more than 70% or more than the lower limit of normal. And by doing this, I know this patient has severe obstructive airway disease with air trapping and hyperinflation and severe reduction in diffusion capacity.
Excellent. Wonderful. So this is just elaboration to what Dr. Mohammed said. This is the volume flow curve, the volume time curve, and that's how it looks in the normal patients. You can look that the volume can be up to like 4 liters in 1 second in normal patients, and this is in patients with obstruction where the number is limited. Dr. Anas, can you look at this chest X-ray and tell us what do you see in it? Dr. Anas?
السلام عليكم. بسم الله الرحمن الرحيم والصلاة والسلام على رسول الله. شكرا أخي فيصل. أهلا وسهلا بجميع الزملاء والأساتذة. Yes, so this chest X-ray is a bit not very straightforward. However, you can tell this is there is flattening of the diaphragms, there's hyperinflation. There may not be a tubular heart. I can't see any evidence of opacities or masses or consolidations, and not a lot of congestion. I'll not tell you that this is an emphysematous lung. However, the patient is relatively obese, and I can't really tell anything else.
Okay, that's great. So based on all of this information, Dr. Anas, what do you think? What is the diagnosis?
So I think to anybody looking at this, the diagnosis is quite clear, COPD. However, this is the idea of this podcast is not just say this is COPD. Now, how does this reflect on our practice? And let's assume that you practice in Libya, and this is a Libyan patient, and we need to consider that not all patients have access to spirometry, and certainly we don't have residual capacities and residual volume, and transfer factors, diffusion capacity. These tests are literally not available. And the question is, what would you tell your patient? So do you say, well, عندك شوية بردة، عندك بقايا دخان، عندك دخان، عندك التهابات مزمنة، عندك شوية تحسس، عندك خلايا، عندك. What do you actually say to your patient? Okay, so we agree this is COPD. My advice, and this is why I do in my daily practice في العيادة في ليبيا, you use the term الانسداد. طبعا you can make it mouthful, يعني تقدر تقول مرض الانسداد الرئوي المزمن, and you can repeat this and you can put this in writing. لكن كلمة الانسداد هذه أعتقد أن هي it gives you the ultimate term that we are referring to COPD. تقدر تقول الانسداد المزمن، تقدر تقول COPD، تقدر تقول الأشياء هذه كلها.
Perfect. So, Dr. Anas, why do you think this is COPD? Why so انسداد انت سامحني بس انت دائما تقول انت قلت لنا انسداد بس we know that obstructive patterns that can be also in bronchial asthma or some other diseases. So why this is COPD and something else?
Yes, okay. So you have the clinical information, which is the history and examination. You also have the physiological data. Now, if you look at the patient's history, there's been a number of exacerbations of baseline symptoms, mostly in keeping with breathlessness, wheeze, and clinical examination finding of a barrel chest indicating chronic air trapping and hyperinflation. And also there was wheeze, and there was also a split P2 indicative of possibility of there being pulmonary or pulmonary hypertension. So all these features are in keeping with COPD. Fact that he is a smoker and is of the higher age. I can't remember the patient's age, was it 72?
68.
68.
68. So this is the age population, it's the correct sex, it's the correct risk factors. And as Dr. Megri has demonstrated very nicely, the spirometry reversibility is only 2%. And as we know, to have a significant reversibility, we need to achieve either 12% or 15%, أو 200 cc أو 400 cc. This is far from reversibility. كذلك, COPD is associated with a reduced diffusion capacity. Asthma is not.
Excellent. Excellent. Okay. طيب السؤال الحين السؤال الآن لأخونا دكتور محمد المقري. Do we really need the spirometry to confirm the diagnosis? The patient has perfect history, perfect story for COPD. Do we really need that PFT and make the hassle of doing PFTs?
So yes, this is an excellent question, and unfortunately, we have like almost 30% of patients that are like misdiagnosed, or like they are not diagnosed with the COPD because of like, or we tell the patient that you have COPD just according to symptom. المشكلة إن بالدefinition لازم يكون عندي spirometry باش أنني نقول هذا البيشنت عنده COPD. لازم يكون عندي risk factor, which is smoking, biomass, like occupational indoor or outdoor pollution. والحاجة الثانية عندي symptom of chronic bronchitis, cough, sputum production, shortness of breath. And on top of it, spirometry has an FEV1 to FVC ratio less than 70. If he doesn't have an FEV1 to FVC ratio less than 70, then we cannot call it COPD. However, if he has a symptom and risk factor, this is a pre-COPD. So these patients could get COPD in the future, but for now, we cannot say definition COPD. But if I'm in a place in Libya, I don't have spirometry everywhere. So maybe I will treat this patient as a COPD until I have the time to obtain a spirometry. So it's not easy. Like in here, you just do the spirometry anywhere. It depends on where you are practicing and where is the clinic and the patient ability to do the spirometry.
Exactly. So if you have the ability to do it, what I gather from what you said is if I have the ability to do it because it has a lot of useful information for my prognosis and treatment and accurate diagnosis of the patient. If not, then I will use my clinical judgment and my best clinical sense in order to treat the patient.
That's right.
Okay. Let's move to the next one. I think we kind of answered this, which is the how to differentiate between the asthma and the COPD. And as Dr. Anas and both of the guests actually highlighted, that airway hyperreactivity is the main key factor, but there is always this gray zone in between where the patient might have both diseases in the same time. And also, as both of our guests highlighted, that the patient population is different, and for the most part, the asthma, the trigger is a big important feature in the diagnosis, and smoking history and emphysema is another important feature of the COPD. Okay, let's move on to the next thing, which is the severity. And I think the question now is to Dr. Anas Zarmouh. Based on the pulmonary function test and the symptoms and everything, what do you think is the severity of the COPD? Is it mild, moderate, or severe disease?
Right. So we have two classification systems as the GOLD guidelines, and unfortunately GOLD have changed. يعني هم في 2011 طلعوا لنا ال ABCD system، بعدين في 2018 تقريبا او 2019 قالوا لنا ان ال ABCD system هو اللي بيدير الجايدنس للتريتمنت، لان لما طلع الاي بي سي دي سيستم في 2011 هي عباره عن كلاسيفيكيشن وخلاص، ما قالوش لنا راهو هذا بيكون جايد تو يور تريتمنت. الان حولوا الاي بي سي دي سيستم وخلوا لك الاي بي اي سيستم. طيب also they've also kept the old classification اللي هي according to severity of obstruction. فالآن we have two classifications, and which one do you actually turn to? This patient has had a lot of problems, and he has a very bad spirometry, and he's had a serious admission to ICU or high dependency unit requiring BiPAP. And he has a very poor exercise tolerance. Now, Faysal, your introduction said that he has to stop before walking or after walking 50 meters or 50 yards. And that gives him a poor MMRC at 3. And he's had a serious ICU admission or a serious hospital admission, and that gives him an exacerbation risk. So this guy is sitting in group E. And if you're looking at the old grouping system, then you're looking at group D. So I think these are the things that we need to look at. If you want to classify his obstruction or severity of obstruction, then what was his FEV1? I think it was 23, wasn't it?
23, yeah. 23% after birth.
So this is less than 30. So this is called for very severe. So this guy prognostically has a relatively high mortality rate in comparison with other COPD population.
Yeah. So from what I hear from you, Dr. Anas, that the severity classification is not simple. It takes a lot of factors in it, like pulmonary function test parameters, symptoms, exacerbations, number of exacerbations, need for admission to the ICU. But for symptom severity, you kind of hinted onto this. Symptoms is a subjective thing. The patient complains of symptoms. Is there any way how we can objectify the severity of symptoms?
Yes, so there is the CAT score, which is the COPD assessment test. However, this is not validated for Libyan population. It's in English language, so we cannot use it on the Libyan population. With regards to the MMRC, this is what we use in clinic, and this patient will qualify for a grade 3 dyspnea, which is MMRC 3. And if you look at the number of exacerbations, then this can be objectively quantified.
Excellent. Okay, perfect. So from what I hear from you, that we can use this parameters or this grading scale in order to objectify the patient's symptoms and get more objective measure that we can use in the GOLD staging. So a lot of, as you mentioned, there are a lot of complex scoring system and severity assessment. And as you mentioned earlier, the GOLD compiled this all in this paragraph. I will ask Dr. Mohammed to walk us through this paragraph or through this, this assessment tool for the GOLD.
Yeah, so if we start with symptoms, so patient, everything is symptoms. That's the first thing. That's why we are physicians, is that right? So I look at the MRC score in here. So if the patient, as you said, المريض ما يقدرش يمشي 15 meters ويدهش مثلا بعد 15 meters. So I know now here his grade is 3. So ما دام grade is 3, that we have more than 2. صحيح? So he's in P, B, or E. So I know now, I'm out of A. So then the next step, he had multiple exacerbation and he had hospitalization. So in here, he has more than one hospitalization. He has multiple exacerbation. So I know I ended up now in a GOLD E. So this patient has a GOLD classification E. However, this doesn't matter شنو اللي يكون ال FEV1 متاعه. لو ال FEV1 متاعه إن شاء الله حتى ال FEV1 متاعه 80, he still could be GOLD E. If ال FEV1 متاعه less than 30, he still could be any GOLD. So the classification, it doesn't go with the grading. So in 2011 كانت مع الجريدنج تو نحوها. يعني أنا عندي مثلا المريض هذا كان very severe GOLD 4 لأنه 23% وهو حاليا GOLD E, which that will guide us for our treatment.
طيب Dr. Megri, again, why this complexity? Why we need to do the grade if we can use the ABCD or ABCE or ABE, scoring system? Why I need to do the FEV1? What's the value of that?
That's right. So FEV1 can be used for prognosis for the patient and mortality. So there is a score called the BODE score, the BODE score, and that can be used. You put the symptoms, you put the FEV1, you put how much the patient can walk, and you know, like what's the severity. Like, let's say that if this patient BODE score is 7, then I will start thinking of like this patient need to be referred for transplantation. This patient need to refer to some like other intervention. If his score like less than that, so I know that his mortality, and بتغير حتى طريقة الكلام مع المريض. لما المريض بنقول له انت عندك risk factor very high والبروجنوز very high، يعني هذا يؤدي الى يعني الchance بتاعك number wise you might die, but like if it's 18% survival in the next 4 years. عرفت؟ يعني حتخلي المريض اكثر يركز في العلاج بتاعه واكثر انه يركز في المتابعه بتاعه. هذا بالنسبه للgrading of the COPD itself. بالنسبه للclassification, that's for the how to initiate therapy, like what treatment the patient should be initiated to according to the A, B, or E.
Excellent. واضح جدا دكتور أنس. دكتور محمد. تو دكتور أنس، أي ورك اب تاني شنو في ورك اب تاني تدير فيه المريض السي او بي دي؟ بعد جانا المريض درنا له pulmonary function test، درنا له chest x-ray، شنو في other work up I can do that will help me in deciding or differentiating the diagnosis of the patient and initiating treatment?
طيب هو there's more than one direction we could move in. So in trying to further assess the severity of your COPD patient, you could request a CBC with differential count or a full blood count, depending on where you work. You could get a FeNO or a fraction of expired nitrous oxide. Also, on top of all these, you could do a 6-minute walk test if that's available, and that will give you a baseline to move on to. Looking at the other comorbid conditions, especially things that overlap with your diagnosis, because there may be an undiagnosed underlying heart failure or left heart disease or coronary artery disease. So you may be looking at doing pro-MP, ECG, perhaps doing an echo, see a cardiologist if you suspect there may be a comorbidity.
Excellent.
Alpha-1 antitrypsin, you would request an alpha-1 antitrypsin if your patient is 20, 30, 40-year-old. And if they've had if they're relatively old and they've had a consistent smoking history, then I wouldn't really get an alpha-1 antitrypsin. So this is not for all your COPD patients. If things get complicated and you don't know where to go, then HRCT to assess the lung parenchyma may also be a good way to do things.
Okay, طيب ليش نديروا السي بي سي؟ ليش نبعثوا في الاكسل نيتريك اوكسيد؟ How's that going to change our treatment?
Yeah, so as the slide mentions, very easy question that is. So eosinophils have been associated with a possibility that these patients would respond to inhaled corticosteroids. Now, as we know, the FLAME trial, which is proven that LABA-LAMA combination is superior to a LABA-ICS combination, and it has less side effects in terms of pneumonia. Now, if you look at the subgroup analysis for these patients, there has not been they've not looked at the eosinophils. Some other studies have looked at the eosinophils, and they have found that there is an association with reduction in a number of exacerbations if you use ICS on patients with higher eosinophil count. Now, the cut line in the cut line في الguideline هو 300. لكن many papers and many experts will say لو حصلت 150 أعطيها ICS. فهو الجايدلاينز يقول 300 تمام صحيح. لكن لو حصلت 100 أو 150 على peripheral eosinophils تقدر تعطيه ICS and you should expect some good results.
Excellent. Okay, just for the sake of time, this is a big topic, and we can talk about the workup and the diagnosis for hours. But let's move on to treatment, because that's one of the most important things that's why the patients are actually coming to us, is mainly to treat them. So, Dr. Mohammed Al-Megri, what are your goals of treatment? what are you trying to achieve with the treatment? Is there any lines of treatment, any goals of treatment that you think of before you start?
أهم حاجة يعني I have to reach the point between me and the patient, that the patient understanding this is, unfortunately, it could be non-reversible. Yes, it has a little bit of reversibility. We can treat it, but however, he needs to understand that most of the treatment اللي احنا نستعمله فيهم توا, it's for symptom control and to decrease the rate of the exacerbation. And lately, like there is like the triple therapy showed maybe that will show improvement mortality if you put like one inhaler in the ATIS trial and the IMPACT trial. لكن لما نجي نتكلم على الهدف متاعي اننا يعني to improve patient symptom, decrease the rate of exacerbation and trying to decrease the rate of hospitalization. that هذا الهدف الاساسي من التريتمنت متاعي. واهم حاجه الeducation المريض. That's he needs to know what's the disease he has and how to educate him about إن كيف التريتمنت وكيف classification of treatment which one that it should be used and which one should be not used.
Okay, excellent. Okay, so I will not ask questions about this slide because the treatment, as you mentioned, there are so many lines of treatment in the patients with COPD, and each one of them is very important. So we need to focus on it and give it its full time. So for the sake of time, we're going to talk today only about the inhalers, but the rest of the treatment will be addressed in future episodes. Okay. So my question now is to Dr. Anas Zarmouh. You can see in this slide, there are so many inhalers. There are like tens of inhalers that can be confusing, different manufacturers, different chemical ingredients. It's very confusing. Which inhaler we should pick, what we should give the patient, what inhaler we should prescribe to the patient. Do you have any guidance to that?
Yes, so I think in addition to your inhalers, they've added biologics to your list of medications, just to make things a bit more exciting. So basically, I think if you look at inhalers, your classifications are into basically beta agonists and muscarinic antagonists and inhaled corticosteroids. Now, if you look at the beta agonists, we have formoterol, salmeterol, بالإضافة إلى salbutamol. اللي متوفر عندنا في ليبيا اللي هو formoterol, salmeterol does not exist بروحها يعني بشكل منفصل. Like formoterol is very widely used ومشهور بأن هو فوراديل تقريبا by Novartis. Muscarinic antagonists, tiotropium, very widely used, widely available اللي هو tiotropium, Spiriva, aclidinium and umiclidinium تقريبا by Novartis is also available. Lakin it's more available as a combination, as a LABA-LAMA combination, and it's available within the endocateral. Inhaled corticosteroids, you've mentioned fluticasone, beclomethasone, we have budesonide in addition to these, and these are easily available in fixed dose combinations. So these are the main inhaled classifications or inhaled drug classifications.
So this is the drug classes, but what's the difference between them? It's like, is there any specific difference between them, or we can use any of them?
Yeah, so basically what you have is, as Dr. Megri mentioned, inhaled corticosteroids, you've mentioned fluticasone, beclomethasone, we have budesonide, in addition to these, and these are easily available in fixed dose combinations. So these are the main inhaled classifications or inhaled drug classifications.
Okay, so this is the drug classes, but what's the difference between them? It's like, is there any specific difference between them, or we can use any of them?
Yeah, so basically what you have is, as Dr. Megri mentioned, you need to classify your patient. So if you have an ABE patient, a patient sitting in E, and this is their first assessment, then you probably want to give them a LABA-LAMA combination instead of just giving them one single inhaler and just checking. This is according to the 2023 guidelines. If you have a patient on B, for example, you also give them a double or a dual inhaler or a dual bronchodilator inhaler instead of just trying them with one. Group A patients, they just get a Ventolin inhaler and see how they go with it. So this is the simplified way of doing things. In terms of go on. In terms of types of delivery devices, now with the metered dose inhalers, patients خلينا نحكي بالعربي شويه. مشكله الام دي ايز ان المريض يحتاج الى قدر كبير جدا من انه هو يكون واعي وعنده قدره على التنسيق بين اخذ البخه واخذ النفخه، اخذ النفس، وبالتالي يحتاج الى قدر كبير جدا من التركيز، وهذه في كثير من الاحيان صعبه خاصه في الالدرلي patients اللي هم beyond the age of 50-60. and I'm not being ageist, this is what we actually find in clinic. Dry powder inhaler, they are easy to use. However, المشكلة أن المرضى ما عندهمش القدرة الكافية البيك inspiratory flow rate أو الانسبيراتوري flow rate الكافي باش هو يستعمل توربو هيلر أو الديسك هيلر. فهذه مشكلة أيضا. فهو أنت قدامك في العيادة إذا كانوا طلع التوربو هيلر أو الديسك هيلر واستعملها قدامك وهو ما عندهاش القدرة، واضح أنه يعني you don't have to measure الانسبيراتوري فلو ريت بتاعه، لكن اذا كان هو واضح انه هو ما عندهاش معناها يعني انت you're just wasting your time. الافضل انك انت تعطيه ام دي اي وتدير له تريننج على الام دي اي، واذا كان ما نفعش تريننج على الام دي اي تدير له سبيسر، و everybody will succeed on a spacer plus an MDI. The soft mist inhalers بصراحة there's limited options in terms of drug therapy, and they're also not available and they're relatively expensive. But they have fantastic drug deposition. يعني إنهم ممتازات لو حصلتهم.
Excellent. Yeah. So this Rispemat device is very good. Like the compliance of the patients, and like the patients loves it because it's easy to use. I will add one line, Dr. Anas, which is, I'm not sure if it's used widely in Libya, but here in the United States, we use it a lot in patients who cannot afford any of these inhalers. I like to prescribe them actually nebulizer medication. Like I give them budesonide nebulized budesonide زائد Junips. خليهم ياخذهم مرتين او ثلاثه في اليوم. طبعا مش زي الانهيلر، ما يقدرش زي الانهيلر يبخها وتمت، لازم يقعمز نص ساعه او ثلث ساعه باش ياخذ النبيلايزر تريتمنت بتاعه كامل.
I'd love to see any piece of evidence supporting the use of nebulized corticosteroids on short term or long term in any kind of form. I've previously looked, and this is heavily marketed, by the way, in Libya, heavily marketed. Pulmicort and fluticasone nebulizers, heavily marketed. Like, I cannot see any evidence really. So if you do have any piece of evidence, please let me know.
هو just sorry to interrupt for a second. So هو يعني most of evidence and the retrospective trials showing that the patient اللي هم على MDI أو patient اللي هم على dry powder inhalers يعني as we know it's only 25 to 30% of the medicine it will be delivered. That's لو إنك أنت طبقتها بالطريقة الصحيحة 100%. تمام. يعني أنت educated وكل شيء تمام. فنعمة نستعمل في النبيلايزر لابالاما او لابالاما اي سي اس نبيلايزر امتى؟ لما البيشنت he cannot take inhalers. يعني لما انت البيشنت he cannot take inhaler, he cannot take MDI, he cannot take DPI. I don't need an evidence. I need I know the evidence treatment is the patient will be treated, and that has been retrospectively seen, and patient symptom improved when they use the nebulizer if the patient cannot use any type of these inhalers. But I agree with you, as a first line therapy, as Dr. Anas said, there is no evidence saying, oh, no, let's just go ahead with the ICS from the beginning and that will improve mortality or symptoms.
Excellent. Exactly. I can't agree more. So let's move. Okay. So which inhaler regimen, so which inhaler regimen we should pick? These are delivery devices, and the different combinations are can be made with these devices. So what are the criteria of selection of inhalers, if we may say? And this is the questions for you, Mohammed Megri.
So yeah, a quick answer for this, as we said, you said and Anas said, it depends on the patient. So it's severity of the patient, the classification of the patient. For this patient, we decided that he's a class E, is that right? So and he was in the hospital. كيف درنا له discharge من المستشفى. يعني هذا الأغلبية يعني they will start on triple therapy. يعني triple therapy اللي هو لابا لاما ICS. في واحد يجي يقول لا دقيقة ما احنا قلنا بنشبه البريفرال eosinophil count first. المشكلة في النوعية من الناس هم you cannot look at the peripheral eosinophil count. يعني most probably he received steroids in the hospital. يعني most probably he already received like systemic steroid and his peripheral eosinophil count was low. لكن الأغلبية نبدأ بلابا لاما and ICS and then in the follow-up I would look at the peripheral eosinophils and if it's more than 100 I will keep with the treatment. If it's less I will start weaning off as the sunset and the wisdom trial. لكن الفكرة أهم حاجة عندي إنه هو يعني لو إنه هو grade A patient will go with LAMA only and it showed like better effect, decrease in exacerbation and improving FEV1 comparing to LABA only. لو patient class B will do LABA-LAMA combination. If the patient class E and I saw him in the clinic, I will do LABA-LAMA combination as well with the education and everything. And I look at the peripheral smear. If the peripheral smear is more than the 100 or 150, then I will start them on inhaled ICS. As we know, why I'm trying to avoid the inhaled ICS, because there is a high risk in the TORCH trials showed that there is an increased risk by 10 to 30% for pneumonia.
Yep. Can you see this slide?
Yes.
It's a picture on top of the presentation. I'm sorry, I didn't update the presentation. But this just highlights what or summarizes what Mohammed was saying. Okay, I'll move on now to the use of ICS, when we should use the ICS, and we already touched on this. But what's the problem with using ICS? Why we are so cautious with the ICS?
As I said, it's because like the TORCH trial, when they compared the fluticasone with the salmeterol comparing to like a placebo or like a salmeterol by itself, found that patient, yes, they have better symptoms, but they have more risk of pneumonia.
Excellent. Okay. All right. So I'll skip this slide because it will be presented in the next episodes. I think it's about time. So I'll just summarize what we learned in this discussion. So first of all, I would like to thank our guests for this excellent to the point answers for our questions. Thank you very much Dr. Anas and Dr. Mohammed على الوقت بتاعكم وعلى sharing your wisdom and knowledge. The things that I learned today was that COPD is not a simple clinical entity. It's not just inhaler that you prescribe to the patient, he goes home. COPD is a complex entity that affects the patient outcome, that affects the patient's quality of life, and need to be taken seriously. Spirometry is an essential tool for the diagnosis of COPD. However, if you don't have it, you should use your best clinical judgment. Staging is a critical step of management of COPD. It helps to guide the treatment, helps to predict outcomes and prognosis of the patient. Determining the main trait, which is knowing what's happening with the patient. Is the patient's mainly symptomatic, having worsening shortness of breath? He's always short of breath. He doesn't go to the hospital frequently, but he's always short of breath. Or he does not have baseline shortness of breath, but he's very prone to have exacerbations and he needs to go to the hospital being admitted for COPD exacerbations. This will guide my selection of inhaler. And finally, we need to understand what's available in the market. What are the inhalers? What's the composition of those inhalers? What's the delivery technique? And what's the best technique of inhalers that we should use? I'm going to send you a link at the end of this presentation that demonstrates the technique of using the different inhalers. This is very helpful to understand and to teach the patient. Thank you very much. And